Do you ever leave the bathroom and still feel like you haven't really left it? Like something is unfinished? A quiet, embarrassing drip that follows you, stealing your confidence one drop at a time. I want you to pause here not as a patient, but as a human being who deserves dignity in the smallest, most private moments of life. Urine dribbling, what many of my patients whisper about with lowered eyes, is far more common than you think. Yet the silence around it makes it feel isolating, almost shameful. But your body is not betraying you. It is communicating. In men, especially after the age of 40, post-void dribbling often happens because the urethra, the tube that carries urine out, holds back a small residual pool. Weak pelvic floor muscles, prostate enlargement, or incomplete bladder emptying can all contribute. In women, it may follow childbirth, hormonal shifts, or pelvic floor weakening, the quiet aftermath of giving life, yet rarely spoken about. And psychologically, the impact is deeper than the symptom. I've seen confident professionals start planning their day around washrooms, young men avoiding light-colored clothing, women carrying silent anxiety in social settings. Because when you cannot trust your body's closure, your mind never fully relaxes. But here is the truth that changes everything. Urine dribbling is treatable. Sometimes, the solution is as simple and as profound as retraining muscles you've never consciously felt. Pelvic floor exercises, what we call Kegels, strengthen the hammock of support beneath your bladder. A technique I teach my patients is urethral milking, gently pressing behind the scrotum or along the urethra after urination to release trapped urine. If the prostate is enlarged, targeted medications and in some cases minimally invasive procedures can restore proper flow and emptying. And for women, pelvic physiotherapy combined with hormonal support can rebuild control that once felt lost. But I always remind my patients, healing begins the moment shame ends. Your symptom is not a personal failure. It is physiology, not weakness. So if you've been living with this quiet inconvenience, adjusting your clothes, your posture, your confidence, I want you to replace silence with action. Because relief is not only possible, it is expected when you seek the right care. Your body is asking for attention, not apology. And when you listen to it with courage, control returns, dignity returns, and most importantly, peace returns. Do you ever walk out of the bathroom and within minutes feel the urge pulling you back again? Not pain, not exactly pressure, but an unfinished sensation. As if your bladder whispered, "I'm not done with you yet." Many people describe it to me in almost apologetic language. "Doctor, I just went, but I still feel like I need to go again." And beneath that sentence lives confusion, frustration, sometimes even fear. Because the mind begins asking questions the body hasn't answered yet. Is something wrong with me? Is my bladder weak? Is this how aging begins? I want you to understand something deeply reassuring. That lingering urge, the feeling that your bladder is never fully empty, is not imaginary. It is neurological, muscular, and psychological all at once. Your bladder is not just a storage pouch. It is a highly intelligent, muscular organ, guided by nerves that communicate constantly with your brain. When functioning in harmony, the bladder fills quietly, stretches comfortably, and sends a clear signal only when it reaches an appropriate threshold. But when this harmony is disrupted, signals become distorted. You may empty your bladder physically, yet neurologically, the completion signal never arrives. So your brain keeps you in a loop of alertness. One of the most common reasons is incomplete bladder emptying. In men, prostate enlargement often narrows the urethral passage. The bladder works harder, squeezes longer, yet cannot expel urine with full efficiency. Residual urine remains behind, like unfinished business. Even a small residual volume can trick the bladder into thinking it is still partially full, and the brain, receiving this message, keeps generating urgency. In women, the mechanism often differs, but the experience feels identical. Pelvic floor weakening, especially after childbirth, can alter bladder positioning and urethral support. The bladder may not compress fully during voiding, leaving residual urine behind. There is also the role of bladder hypersensitivity. Some bladders become neurologically overactive, reacting to even minimal filling as if it were an emergency. We call this overactive bladder physiology. But psychologically, what fascinates me most is how quickly the mind adapts to this sensation. Patients begin preventive urination. They go before meetings, before car rides, before sleep, before leaving home. Not because they truly need to, but because they fear the urge returning. This trains the bladder into smaller and smaller capacity thresholds. It becomes conditioned to signal urgency prematurely. A bladder that once comfortably held 400–500 milliliters may start panicking at 150. The organ hasn't weakened. Its behavioral training has changed. I often tell my patients, the bladder has memory. Not emotional memory like the brain, but functional memory shaped by repetition. Another overlooked contributor is chronic urinary tract irritation. Even without active infection, inflammation of the bladder lining from past UTIs, stones, or chemical irritants like excessive caffeine can make the bladder wall hyperreactive. Imagine skin after a burn. Even light touch feels exaggerated. The bladder behaves similarly when irritated. Then there is diabetes. Elevated blood glucose increases urine production and affects bladder nerve function. Patients may empty frequently, yet never feel satisfied. Neurological conditions, even subtle ones, like lumbar nerve compression, can disrupt the bladder-brain signaling loop. But beyond physiology lies psychology. Because the bladder is deeply tied to safety perception, in evolutionary biology, urination is a vulnerable act. The nervous system prefers controlled, private conditions. Chronic anxiety keeps the body in low-grade hypervigilance. Muscles, including pelvic muscles, never fully relax, so even during urination, the pelvic floor may remain partially contracted. This prevents complete emptying. You finish voiding, but your muscles never allowed full release. The result? Residual urine and persistent urge. I've had patients whose symptoms improved not with medication, but with anxiety regulation and pelvic relaxation therapy. Because sometimes the bladder is not the origin of the problem, it is the mirror reflecting systemic tension. Certain medications also interfere: antihistamines, antidepressants, decongestants by affecting bladder contractility or sphincter tone. And then there is aging not as a disease, but as a physiological transition. Bladder muscle elasticity changes, nerve conduction slows, prostate tissue grows, estrogen declines. The system still works, but less synchronously. Which brings me to something deeply important. Feeling the urge after voiding does not automatically mean severe disease, but it does mean your bladder is asking for evaluation, and the solutions are often less invasive than people fear. Bladder retraining is one of the most powerful. Gradually increasing the interval between urinations teaches the bladder to recalibrate its urgency threshold. Pelvic floor physiotherapy helps coordinate relaxation during voiding, not just strengthening, but controlled release. Timed voiding schedules restore rhythm to bladder signaling. Reducing bladder irritants, caffeine, artificial sweeteners, carbonated drinks lowers mucosal sensitivity. And when prostate obstruction is present, medications that relax the bladder neck or shrink prostate tissue restore efficient emptying. Ultrasound post-void residual testing gives objective insight into how much urine remains after urination, turning anxiety into measurable data. Because uncertainty magnifies fear, but measurement calms it. Now let me take you into the night. Because some of you experience something even more disruptive. You fall asleep, only to wake hours later with the unmistakable call to urinate. You go once, return to bed, drift again. And then it happens again. And again. Nighttime frequent urination, what we call nocturia, is one of the most psychologically exhausting urinary symptoms. Not because of the urination itself, but because it fractures sleep. And when sleep fractures, the mind follows. Patients tell me, "Doctor, I'm more tired waking up than when I went to bed. Even weekends don't refresh me. I feel older than I am." Because deep sleep is where hormonal restoration, memory consolidation, and emotional regulation occur. Interrupt it repeatedly and the nervous system never resets. Now, here is where understanding nocturia becomes crucial. Many assume it is simply drinking too much water at night. Sometimes that is true, but often, nocturia is systemic. In men, prostate enlargement again plays a major role. Reduced bladder emptying during the day leads to frequent night awakenings. But there is also nocturnal polyuria, where the body produces excessive urine specifically at night. This can be linked to altered antidiuretic hormone secretion. Normally, this hormone reduces urine production during sleep. If its rhythm is disrupted due to aging, sleep apnea, or endocrine imbalance, the kidneys continue producing daytime levels of urine at night. The bladder fills repeatedly, forcing awakenings. Sleep apnea itself is a hidden contributor. Interrupted breathing lowers oxygen saturation, triggering hormonal responses that increase urine production. Many patients treat nocturia for years, only to discover untreated sleep apnea was the origin. In women, menopausal estrogen decline thins the bladder lining and alters sensory thresholds, increasing night urgency. Pelvic organ prolapse can change bladder angle and capacity, contributing to incomplete emptying and nocturnal frequency. Then there are cardiovascular factors. Fluid retained in the legs during the day redistributes when lying down. The kidneys process this mobilized fluid, increasing night urine output. Patients with mild heart or vascular insufficiency often notice swollen ankles by evening and frequent urination at night. Diabetes, again, plays a dual role, increasing urine production and altering bladder sensation. But psychologically, nocturia carries a unique burden, because night amplifies vulnerability. The house is silent, the body is half asleep, the mind less defended. Repeated awakenings create anticipatory anxiety. Some patients lie in bed waiting for the urge, unable to relax deeply, monitoring their bladder instead of surrendering to sleep. This hyper-awareness further fragments rest. And fatigue accumulates not just physical, but emotional. Chronic sleep disruption is linked to irritability, low mood, reduced cognitive sharpness, and even metabolic changes. So treating nocturia is not about convenience. It is about restoring neurological and psychological recovery cycles. Management begins with pattern recognition. A frequency volume chart documenting fluid intake, urination timing, and night awakenings reveals whether the issue is bladder capacity, urine overproduction, or sleep disruption. Evening fluid moderation helps, but not dehydration. Salt reduction decreases nocturnal fluid redistribution. Leg elevation before bed mobilizes retained fluid earlier in the evening rather than during sleep. Timed evening voiding ensures maximal bladder emptying before lying down. For prostate-related nocturia, alpha blockers or 5-alpha reductase inhibitors improve night flow. Desmopressin therapy, in selected cases, regulates nocturnal urine production hormonally. Treating sleep apnea, when present, often reduces nocturia dramatically. Pelvic floor therapy improves bladder support and emptying efficiency in women. But one dimension I never allow to be ignored is the emotional exhaustion nocturia creates. Because repeated sleep interruption changes how patients feel about their own bodies. They begin describing their bladder as an enemy, something unpredictable, intrusive, controlling their nights. And when you feel controlled by your own physiology, helplessness grows. So reassurance becomes therapeutic. Understanding that nocturia is diagnosable, measurable, and manageable reduces psychological strain even before treatment begins. I often watch patients relax simply after learning that their symptom has a name, a mechanism, a pathway forward. Because uncertainty is heavier than the symptom itself. There is also an environmental dimension. Poor lighting on the path to the bathroom increases fall risk in older adults, so practical adjustments, night lights, clear pathways, supportive footwear become part of holistic care. Because safety influences relaxation, and relaxation influences sleep depth, which in turn influences bladder signaling. Everything in the body is interconnected far beyond the bladder alone. I remind patients that both persistent urge after voiding and nocturia are communication signals. Not nuisances to suppress blindly, but physiological messages asking for investigation. The bladder speaks through sensation, through frequency, through urgency, through interruption. And when listened to carefully without embarrassment, it guides us toward underlying imbalances that are often correctable. Ignoring it prolongs distress. Acknowledging it begins restoration. Because continence, comfort, and uninterrupted sleep are not luxuries. They are biological expectations your body is designed to provide when its systems are aligned. And when they drift out of alignment, gentle, methodical correction brings them back toward equilibrium, restoring not just urinary control, but the quiet psychological confidence that comes from trusting your body again, in the day and in the unguarded stillness of night.